I'm coming to you today from Whadjuk country. In the spirit of reconciliation, we'd like to begin today by acknowledging the traditional owners of the various lands we are coming together on. We recognise their continuing connection to the land, sea and community. We pay our respects to their elders past and present, for they hold the stories, traditions, the culture and hope for their people. My name is Linda Thompson and I am a blood cancer support coordinator and haematology nurse. Along with my colleagues, Tani Hodgetts, a clinical content producer and a background in haematology nursing, and Linda Saunders, a National Education and Support Group Program Lead with a background in cancer social worker, we will be running today's seminar. In this second session, demystifying the process of autologous stem cell transplants, we will be focusing on the procedure itself. This will include what to expect in hospital, the conditioning process, the infusion itself, psychological preparation, and managing physical reactions. So just a little bit of housekeeping before we go on, practical reminders. This session is being recorded. Please keep your cameras off and your microphones on mute for the presentation. You can add questions and comments in the chat. These will be collated and addressed in the Q&A after the presentation. We have shared the pre-submitted questions with our guest speakers. Please understand we're not able to answer specific medical or highly personal questions. And for the best experience, please have your view on speaker view. I'd like to introduce Michael O'Gorman. Michael is in his late 50s and lives on the Sunshine Coast in Queensland. He was diagnosed with myeloma in 2011 in his mid-40s, and he underwent an autologous transplant 10 months after his diagnosis. Michael is currently in chemical remission and attends hospital weekly for Velcade. Most importantly, he's an avid triathlete and is about to celebrate being married to his wife Lynn for 25 years. In addition, he's a very proud father to his daughter Taylor and recently became a grandfather to twin baby girls. Let's hear a little bit more of Michael's story. Welcome, Michael.
Thank you, Linda. Yes, look, thank you everyone for the opportunity to share my journey. When I was diagnosed with multiple myeloma, I had 24 broken bones, including all my ribs, most of my vertebrae. The doctors were going to fuse my spine. My kidneys are all about to fail, and my doctor said, you better get your affairs in order because we can't promise you'll make Christmas. That was October 21st, 2011, a date don't forget. My 11-year-old daughter at the time, my wife was sitting on the bed, and the very, very, very first thing that came into my head was, I have to be there to walk my daughter down the aisle. So no, I'm not going anywhere. So that sense of purpose is something that got me through, and it's something that we all need to get us through this sort of journey that we're on. You see, I thought I'd failed my family, and so from that sense of purpose, I had to get well enough to undergo a stem cell transplant in August 2012. As you all know, your body cops beating physically. However, it's your mental strength that will really ultimately see you through. So I went into Royal Brisbane. I was nervous. I was apprehensive. I was hopeful, but I was also positive because I knew once I had progressed through this stage, I could get on with my life. So I checked in. The room's a bit stark. You know, it's a hospital. It had a window, so that wasn't too bad. You're treated like a VIP, which is all very nice. Your Hickman catheter goes in, which I'll explain to you another time. That's day -2. Day -1, melphalan. Melphalan was my chemo of choice. And there's no way to sugarcoat melphalan. It is designed to strip you clean, and it certainly does that.
Okay.
I'm not here to frighten you. It's as your experiences may be different, but let's put it this way. Mine was unpleasant, to put it nicely. But I'll get into a bit more detail of that in a minute. And then that's day -1. So day 0 is the transplant. The transplant is your rebirth day, and you will celebrate as you normally do on any other birthday. We still celebrate with cake, candles and songs. August the 2nd is my rebirth day, and I celebrate it vigorously every year. The actual transplant is actually quite underwhelming. I thought there'd be sort of marching bands and fireworks and a visit from the Prime Minister, but no, it's just Small pink bag gets attached intravenously, relatively quick, done. Let the fun begin. What follows isn't really fun. You will be tested physically, mentally for the next couple of weeks. You will experience, well, I did anyhow, tears of fatigue, tears of hope, tears of I can't do this, but you will also experience joy as you realise you begin to improve and your numbers begin to improve. A little bit of fear of what's next, but you will go through the gamut of emotions because you are physically drained. But you will get through and you can't lose sight of that. My advice is leave your ego at the door. Let the medical professionals look after you. They know what they're doing. And you just let go. And I distinctly letting go of my ego because the dignity, you lose your dignity. So after I messed my pajamas one too many times, remember the nurse saying, because it's quite unusual at the time, she said, I know you're a dude, but sometimes you've just got to let go and let us look after you. You're going to have to wear a nappy. So there I was gaunt, weighing about 60 kilo, about 15 kilos less than I normally do, wearing a nappy, unable to eat anything other than ice and ice blocks, and feeling pretty sorry for myself. But it was my wife and my daughter, my support crew, that were there through all of this. My wife would help me shower. My daughter would take me for a walk with Dolly, the intravenous drip, to the courtyard every day, get a little bit of fresh air and some sunlight. We took measures like we banned the C word. We've never used the C word. We referred to what I have as bubbles because it took the demon out of the word. And we banned the word hate because nothing good comes from hate, and it certainly won't help your recovery. We only watched comedies on TV to make sure I laughed regularly as much as it hurt. And my daughter designed a secret handshake to say goodnight, so that the last thing she saw me when she said goodnight was me smiling. And we still have that secret handshake today. I was fortunate enough to have the London Olympics on during my stay, so that helped. And I watched the triathlon with my daughter, and we were both pretty impressed. So, yeah, it's pretty cool. Spur of the moment thing, I don't know why, but I promised her I would complete a triathlon one day to show her that I'm okay. So again, having that purpose, that goal, that sense of reason. So I checked out of hospital on the 26th. I was pretty weak. I was very fatigued. I was tired, but still just full of absolute joy and happiness to be home, ready to start training, ready to get on with life. But keep your expectations in check. I still wasn't eating well. Was very fussy. My go-to food at that time were fish fingers. All I could eat was fish fingers. And iced coffee milk. It was calories and fluid, but if I got it down, it was good. So I gradually improved, and 3 weeks out of hospital, I began training and kept a training rod. But keep your expectations in check. Day 1, walk to the post box and back. Day 2, walk 100 meters. So it's a gradual thing. So give yourself time and just let expectations go. However, I've kept at it, and in November 2013, I completed the Noosa Tri. And my wife and daughter were at the finish line. We hugged, we cried, and I told them I'm okay. Since then, I've completed over 40 triathlons, including a couple of full Ironmans. And last year, to celebrate my 10th rebirthday, I did an Ultraman, which is a 10K swim, a 420K bike, and an 84.5K run. And every time I cross the finish line, I say, I'm okay. So some good things came out of my diagnosis. So I enjoy triathlon, but it's not really about the sport. It's more the sense of purpose and the goals that drive me. But the main thing that drives me is my time with my family. And I didn't appreciate that before. A transplant is a really challenging time. It will really test you, and your mental strength and having your support crew with you will help you through that. So your family and your loved ones will be there ready to embrace you, and they will look forward to celebrating your rebirth days for the years ahead. Thank you.
Thank you so much, Michael. Such a realistic, raw and hopeful insight into your own personal experience. You highlighted some very important aspects about your mental state and the importance of having a goal and a sense of purpose. Michael will be staying on with us to join us for the Group A Q&A at the end. Now, this nicely leads us to introduce our professional guest speaker, Dr. Shirleen Sim. Dr. Sim is a dual-trained clinical and laboratory haematologist. After graduating from the University of Melbourne, she went on to complete her basic physician and advanced haematology training at St Vincent's Hospital, Peter McMullen Centre and Royal Melbourne Hospital. She is currently involved in clinical trials and research at St Vincent's Hospital. Dr. Sim has a wide interest in both malignant and non-malignant haematology and is highly dedicated to providing the best possible care to all her patients. Thank you, Dr. Sim. Over to you.
Thank you, Linda. Hi, everyone. Thanks for attending today's session, and thank you to Leukemia Foundation for the invite to speak today. And I just want to say a big thank you to Michael as well for that truly inspiring talk. So I'm very impressed with all the triathlons, you know, from someone who gets breathless with walking up 3 flights of stairs at work. I'm highly impressed with that. So very well done. Now I'm just going to share my screen. Oh, I don't think that works. Just give me 1 second. Right. Can you guys see that? Yes, perfect. Okay, we'll just go into presentation mode. All right. So as Linda said, I'm Shirleen, one of the haematologists at St Vincent's in Melbourne. I practice in a wide range of haematology, but with a particular interest in multiple myeloma specifically. So today we'll talk about autologous stem cell transplant and the process, with the main focus being hospitalisation. But I will go through the entire process regardless. So this is a summary of the talk today. So firstly, why do we do it? So the role of transplant in myeloma and lymphoma. How do we, as the health professionals, determine if someone's transplant eligible? And then the actual journey itself. So starting from the induction or salvage chemotherapy, the mobilization and collection process, and then followed by the actual high-dose chemotherapy or melphalan, as Michael was talking about, and the transplant journey and the complications we expect in hospital and post-discharge expectations. So I thought I'll start a bit first with why we do transplants, because as Michael has very, very eloquently summarized, it is a big undertaking. And I think it's important as patients, when you're undertaking such a big thing, to firstly understand why you're doing it. It's that sense of purpose, what is the goal of doing this? So that makes it all worth it, really. And so in lymphoma, the aim of any treatment is really for cure. In myeloma, which is another hematological cancer, unfortunately, we can't cure it at the moment. That's, of course, where we're aiming with all the research we're doing. But the aim of treatment is really to get as deep remission as possible and for as long as possible. And to be able to achieve these two goals of either cure in lymphoma or a deep, durable response in myeloma, we really need really high doses of chemotherapy. Now, the problem, though, with really high dose of chemotherapy is that it's very toxic to certain organs in your body. So the way chemotherapy works is that it actually destroys cells that turn over very quickly, and cancer being one of them. But there are some other organs in your body that get equally affected. The first on the left here is the bone marrow. And so the bone marrow, as many of you will know, is the squishy bit in between your bones. It's the factory where all your cells are made. So you make red cells that carries oxygen, white cells that fight infection, the most important being neutrophils, which fight bacterial infection, and platelets, which help you clot when you bleed. And so while the high-dose chemotherapy is great at knocking out your cancer cells, it will also wipe out your bone marrow. So all your blood counts will drop and your neutrophils, the white cells, will go to zero, essentially. The second organ that gets affected quite a bit is the gut. So again, the mucus lining of your gut, anywhere between your mouth and your anal region, it turns over every day. We make new cells, the cells die, we make new cells. And so these cells are very sensitive as well to high-dose chemotherapy. And the inflammation that can happen can cause a lot of symptoms, nausea, vomiting, diarrhea, etc. And so really, when you get high-dose chemotherapy, it's this long periods of having low white cells and gut toxicity that becomes a problem. So an autologous stem cell transplant essentially provides a good solution to this. So what is an autologous stem cell transplant? So stem cells are, think of them like seeds, and they're very talented seeds. They can grow into many different types of cells. So any of the cells that I talked about essentially. And auto means self, which means that we remove the stem cells from your own bone marrow prior to giving the high-dose chemotherapy, and then we give it back to you following the chemotherapy. So this is different from another kind of transplant called allogeneic transplant, allo meaning from someone else. Now, so the concept behind it really is that we give high doses of chemo to destroy the cancer cells, and we follow that up by returning your own previously collected stem cells to essentially what we call rescue the bone marrow. And this allows the marrow to recover and normal blood production to continue. So in the most basic form, an autologous stem cell transplant is a way for us to facilitate giving you high-dose chemotherapy and try to minimize the duration of toxicity for you. Okay, I hope that makes sense. All right. So who is eligible? I won't touch too much on this. Safe to say that, one of the main decision making that we make when we see our patients is, are they eligible for transplant? And that's based on a number of different factors. It's not a one size fits all, but essentially we consider things like age, how well you are, like functional status, and whether you have any other medical problems or heart problems, lung problems that will make going through high dose chemotherapy even more difficult. And I always say to my patients, I might have the best treatment up my sleeve for your cancer, but I need to be able to get you through it. So it's all about balancing toxicity and benefits. So not everyone will be eligible for transplant. I do get asked about age. Do we have an age cutoff for transplant? In general, we wouldn't offer an autologous transplant to patients over the age of 75, even though you might be a fit, healthy 75-year-old, because the organs are still older. Anyone less than 70, as long as you don't really have any other medical issues like heart or lung problems, we would transplant. And anyone between 70 to 75, that's a grayer area, and that's quite individualized. So it really depends on how you are overall. So the two main diseases that we transplant patients for in hematology is firstly myeloma, for the reasons I've already spoken about, and in patients who are eligible, we would use transplant upfront. So as part of your induction treatment, induction meaning the first treatment you get when you're first diagnosed with the condition. In lymphoma, the role and the timing of your autologous transplant really depends on the type of lymphoma. So I've just given a couple of examples here, but I won't go into too much detail. It's a bit outside the scope of this and the focus of today's talk. But for example, in aggressive mantle cell lymphoma, it will be part of your upfront treatment. But in things like diffuse large B-cell lymphoma or follicular lymphoma, we would tend to use it more as second-line treatment. So only if you've relapsed after the first treatment that you've had, and we'll give you what we call salvage treatments or chemotherapy, followed by the transplant to try again to aim for cure. Okay. So this, I've tried to summarize the journey of the transplant itself in a general way that will include both lymphoma and myeloma patients. And we'll now in the next few slides go through each section. So the first, as mentioned, is the induction or salvage treatment. And the reason for this treatment is essentially we want a course of treatment to get control of the disease, remove as much cancer as possible. And in myeloma, the aim is to get the protein levels down, the myeloma levels down by at least 50% or more before we go ahead with the transplant. In lymphoma patients, we would like you to be in complete remission on your scans, or at least a really good partial response before we go ahead for the transplant. And just to make a note that the number of cycles of treatment that you will get before your stem cell mobilization and collection and before your transplant is very much disease dependent. It depends on the treatment regimen that has been chosen, and it can also vary across institutions as well. So let's get stuck into the actual stem cell process. So I think this was covered a bit or quite a lot in the talk last week. So I'll just run through this quickly more as a refresher. But essentially, we start with the stem cell mobilization process. And what this means is, the stem cells that we have, they live in the bone marrow mainly. That's where they live and they stay and they work. And so what we need to do is to give medications to stimulate the bone marrow to make lots and lots of stem cells so that actually leaks out into the blood, and then we collect these stem cells from the blood itself. And that process is called mobilization. Because the chemotherapy you would receive, I hope you can see my pointer, during this induction or salvage treatment here can actually suppress the bone marrow. We try to give the patients a bit of a treatment break before the mobilization, but again, that's a bit disease and treatment dependent, anywhere between about 2 to 4 weeks usually. It also depends on how well the disease is controlled, whether we can wait that long. So your doctor will decide that, okay? In terms of the mobilization process, there are a couple of ways we can do it. The most common being in myeloma being with GCSF, and GCSF stands for growth colony stimulating factor. It's a protein that we have that stimulates and controls the development of your stem cells in your body. So we give a synthetic version. We give it as an injection under the skin twice a day, about 5 to 7 days before we plan the collection. Your nurses will teach you how to administer that at home, or if you don't like needles, your carer can do it, someone in the family, for example. Generally well tolerated. The main side effects people get is really very much bone pain. And this is because what we're trying to achieve, and Michael's nodding his head, you remember, because what we're trying to do is we want to stimulate the bone marrow, as I mentioned. And when your bone marrow is stimulated, it's expanding, it's working really, really hard. So it's painful, essentially. Not everyone gets it, and people get it to different degrees. The main areas you get it, so in adults, our bone marrows are mainly in the long bones of our body. So your thighs, your pelvic area, across your hip, across your lower back. And one of the ones that can be quite shocking for patients is your sternum. So that chest bone right in the middle of your chest, essentially, because you have bone marrow there. And traditionally, we used to do bone marrows from there, actually. Which, yes, a bit shocking. We don't do that anymore. But you do produce stem cells from there as well when you go through GCSF. So don't be surprised if you get bone pain. It is a good thing if you get it. It means that your bone marrow is working really hard. If you don't get it, it's okay as well. Doesn't mean that you're not stimulating your bone marrow. We normally recommend things like Panadol, simple things, but some people do need stronger painkillers for it. And it is temporary. So once the GCSF stops, it will settle in the next sort of day or two. Okay, so it's temporary. In some patients, we give a combination of GCSF plus chemotherapy. To give an example of that in lymphoma, I know I said I'm very myeloma-centric, so I'm trying to make sure I include the lymphoma patients in this. But in lymphoma patients, for example, we will give chemotherapy as part of their treatment, and then we will collect off the back of that. So within sort of 1 or 2 weeks after, we'll give it with GCSF and we stimulate. And that might seem a bit counterintuitive because I just said bone marrow wipes out, chemotherapy wipes out your bone marrow, but essentially we're using that. It wipes out your bone marrow, it brings the levels down, and then your bone marrow goes, "Ooh, I need to recover," and it just goes bang. And there's this recovery of your bone marrow, and if we give G at the same time, we get this rush of stem cells. So that's how that works. Okay. The benefits of with GCS or with chemo is that a higher number of cells collected, or stem cells collected. The disadvantage is that it does have additional side effects with the chemotherapy itself. So nausea, vomiting, or fatigue, infections, that sort of thing. When we use it in myeloma, we use something called cyclophosphamide, which is a chemotherapy. We use it at lower doses. And the aim of chemo in this setting is not actually to treat the myeloma, is to stimulate the bone marrow to make stem cells. Okay. And again, noting that the timing and mobilization methods can vary slightly between institutions, even within Victoria. All our major institutions, we have slight variations in it, but it all works. All right, so once we have mobilized the stem cells, we need to collect it. And before we collect it, we do a blood test to count the number of stem cells in the bloodstream. And if it's high enough and we're happy, we then put you on the machine for collection. And this is done through a process called apheresis. So usually what happens if you plan for a stem cell collection, in the lead up to this, the nursing staff, the apheresis nurse, or your myeloma, lymphoma nurse will bring you around to the room and show you all the equipment so nothing comes as a surprise. It is all a bit anticlimactic. The last patient I had who had it was a bit anxious about it, but ended up sleeping through the entire procedure. So it's quite comfortable. You get in our institution, you have a nice big chair that reclines and you get fed throughout the whole thing. And we do it through something called apheresis. So that's the technique, as you can see on the left here, where stem cells are collected from the blood through this machine, which is a cell separator machine. So you've got a line going in one arm, it takes out the blood, it goes through the machine, and the machine is very smart. It's been programmed to separate out your stem cells. It recognizes it because it's much smaller and much lighter. So it's through gravity. It skims it off, and then it returns the rest of the blood to you through the other arm. There are some patients who may need a bigger line for it if you don't have very good veins, because we like to have good flow. So Michael had mentioned a permacath before, and that's what that is. It sits in the chest, in the bigger veins, and it allows the flow to happen a lot better. And we prefer a permacath for the actual transplant process itself, so we might sometimes keep this in until the transplant itself. All right, so how much do we aim to collect? And this can sometimes cause a bit of anxiety for patients as well. You know, have I collected enough for a transplant? We aim to collect enough for at least one transplant, of course, and that's about 2 million cells per kilo in total. We also like to see whether we collect a bit of extra. And that also depends on age. So for example, if you're 73, you're probably only going to need one transplant in your lifetime because you're about to hit sort of 75 and above. So we only really need one. But in younger patients, we like to collect enough for two in case they need another transplant in the future. Sometimes we don't plan to collect for more than one, but someone mobilizes and collects really well, and we end up with a lot more than we need, in which case we like to store it and keep it for a rainy day, essentially. The collection usually occurs over about 2 to 3 sessions on consecutive days. Each session lasts about 4 to 5 hours. We don't tend to push on for more than about 4 days or so because every day you get collected, it actually goes down, the amount that you can stimulate. And so the use of collecting, you know, putting it on a machine for more days is not very beneficial anyway. During the process, the apheresis itself, there will be fluid shifts, electrolyte shifts, particularly the calcium levels may drop. So the most common thing that people, that we ask people to look out for are things like cramp-like or tingling sensations in your hands or feet or around the mouth. And we do give calcium for that. And then the stem cells are collected in a bag. We bring them to our specialized laboratory. Sorry, I'll just wait for that announcement. And we send it to our laboratory for them to process. And essentially what happens there is that we mix this chemical or preservative called DMSO, and it's mixed into it before we freeze it. And the reason we use the DMSO is because it prevents the sort of the fluid from the cells, the water from the stem cells leaking out during the freezing process, which can actually destroy it. So hence the preservative. And then we store it in liquid nitrogen in the lab until the transplant, and we store it for up to 7 years. If you don't need it, your hematologist can then say, oh, I want it stored longer, and we'll just keep it for longer. So on the right here is just an image of a frozen stem cells. This is what it looks like, a little bit pink. The other question I get asked a lot is what happens if I don't collect enough stem cells the first time round? What happens after? So in that case, we can reattempt the collection of stem cells after a longer treatment break if that is deemed medically safe for you to do so from a disease control perspective. And then on PBS, we can then access a second drug called plerixafor, an even stronger drug, to add to the GCSF injections to try to stimulate more stem cells to come out. So most patients with that will be successful in the second round of collection. Okay. All right, let's talk about the chemotherapy and the transplant aspect of things. Now, I'll start with a bit of terminology and a quick summary, and then we'll go into each part in more detail. So Michael had mentioned day -2, day -1, and really what that denotes the days of the high-dose chemotherapy. So your day 0 is your stem cell infusion. So it's quite different terminology from your normal chemotherapy. Your normal chemotherapy, you say day 1 is the day that you start chemotherapy, and you count from there. For a transplant, you have a day 0, and that's when you get your stem cells infused. So you work work backwards from there when it comes to your high-dose chemotherapy and forwards in terms of recovery. So in myeloma, the drug we use for transplant is melphalan, and we only give it over 1 day. So you get that at day -1. In lymphoma, you actually get usually a combination of 4 different types of chemo, and that starts at day -6. So I've just put here an example of that. Don't worry about the names of the drugs, etc. I just wanted to show how it works. So you can see on the right, you've got day -6. That's when you start. And then from day -5 to day -2, you get another 2 different types of chemotherapy, so 4 doses in total. And then you also get melphalan at day -1, and then you have the infusion of stem cells at day 0. Okay, so you just work backwards. And as I said, day 0 is your reinfusion of your stem cells, and it's given 24 hours post chemotherapy, because if you give it too early, your chemotherapy would just destroy your stem cells, and we don't want that. Okay, sorry, just wait for that. Can you guys hear the? Yeah, okay. So we give it 24 hours post the chemotherapy. It's enough time for the chemo to have washed out, and we give the stem cells, and the stem cells are not destroyed, and it tries to find its way back to the bone marrow, essentially. All right, and day +1 onwards. So we add a plus in the front to denote that it's from the day 0. Here on the right is courtesy of my my myeloma nurse coordinator, which I really like it to denote sort of the journey that you go in the language that we speak nowadays, which are emojis. So we'll go through each process. But essentially, the high-dose chemotherapy wipes out your normal blood cell production. We've talked about this. So at about day +7, so about a week into receiving a stem cell infusion, your counts will start dropping, and this is this area here, this slope here, and a lot of the symptoms you get at this point is actually related to your high-dose chemotherapy, which we'll talk about in a minute. And then you hit the bottom, we call it the nadir, where your counts wipe out completely and your neutrophils are 0. And this is a time for the highest risk of complications and recovery, a lot of the fatigue that has been spoken about. And we wait for what we call engraftment, which is for the stem cells to find its way back into its home, the bone marrow, settle in, and then start to grow and produce new cells. So we expect that onset of the blood count starting to come back and evidence of recovery around about day +10 to day +14. That's when we see it rise. Okay. So we'll go through each area of that. Now, before I talk a bit more about that, I just wanted to flag that there are a couple ways that we can actually do a stem cell transplant. We can do it as an inpatient or an outpatient in some hospitals, not all. Both of these are done in a major tertiary hospital with transplant services, so the mobilization, the collection, and the transplant itself. So if you're from a hospital that doesn't offer it, your hematologist will refer you to another specialty center that can do transplants. Which in itself can sometimes be daunting. You're meeting an entire new team, but just to reassure everyone that we always work very closely with your own primary hematologist and keep them in the loop with everything. And so in inpatient transplant, you get admitted on the day that you're going to receive the high-dose chemotherapy. So that's day -1 for myeloma or day -6 for lymphoma. And in total, it's usually about a 2 to 3 week stay in hospital. And this can vary depending on what complications you get, how quickly you can recover. Everyone's different. But overall, it's about 2 to 3 weeks in hospital. Some centers offer autologous stem cell transplants with an outpatient model of care. In St. Vincent's, we do it for our myeloma patients only, just because the lymphoma regimen is so intense with that many days of chemo prior. We have specific criteria for it. So if you live within 30 minutes of the hospital, doesn't mean that if you come from a rural hospital, you can't do this. We actually provide accommodation or look for accommodation for you, and you stay very close by to the hospital. You must, of course, have a willing and able carer available with you 24/7, so you're not alone. You're physically and emotionally fit, no other complexities involved in your care. And also, the most importantly, you need to be comfortable with it. So you need to feel confident about being able to manage, and your carer needs to feel confident as well. There will, of course, be very regular visits. So there's outpatient where you come to hospital and see the doctors as an outpatient. And we also have a team of hospital and home doctors and nurses who then also come out and do home visits and see you. So you actually get medical contact on a daily basis. You do get priority emergency and ward admission if there are any symptoms concern, and we do then plan an admission to hospital on day +7, and which is the time we expect the counts to bottom out and the highest risk of complications. So we do the outpatient transplant with the aim of you coming in at day +7, and that's a booked sort of bed in hospital. But of course, if we are worried and we think you need more support before that, or you spike a temperature before that, we will get you in before that time point as well. Okay. I guess the benefits of outpatient transplant is that you do spend less time in hospital. So from a mental, psychological perspective, that helps to be out of hospital, so you don't get bored as well. So some patients like that, but some patients don't actually like it. I think, a bit of the anxiety as well. So it just really depends on what suits you. There's no one size fits all in any of this. I've just given a few examples of how this works. So this is our schema. Essentially, you get the chemo on day -1 in the cancer center, and then you come back for the stem cells in the cancer center. And then from day +1 onwards, it's usually a Saturday and Sunday. That's how we time it. You get a visit from the hospital and home team, and then you come back on the Monday, you see one of the doctors in clinic and the nurses, and then the next 2 days you get visited at home again, and then you come back in for another review, and then from day +7 you're on the ward, and we take blood tests every day. Okay, so again, very highly monitored, supported environment, even though you're at home. We give patients, self-assessment forms, because it's, just to help with the carers as well. So you can monitor your temperature, your blood pressure, your pulse every day, 3 times a day. And you can also grade your gastrointestinal symptoms, so your nausea, your mouth pain, if you have any diarrhea, and we have descriptions of that, so you can tell us how you feel. We give patients a card to take with them, so that if there's any temperatures at all, you're meant to ring the hematology registrar immediately. You get emergency antibiotics at home. You take that and you come straight to emergency with this card, and they know it's an emergency and you need to come in straight away. So there are a lot of safety nets put into place, essentially. All right. So what to expect in terms of symptoms and complications at each point of this. Remember that emoji chart I showed you. So with the day minuses, you get the chemo. And as I said, the symptoms that you get will really related more to the chemo in the coming days: nausea, vomiting, or diarrhea. And I just want to flag, but actually before I go into all of this, that you're not going to get every single side effect that I've listed, okay? And I think that can be quite overwhelming when we talk to patients about the transplant process. You go in thinking, oh my gosh, all of this is going to happen. But we tell you this so that you know what to expect, because when you know what to expect, you're prepared mentally for it. And as Michael very correctly summarized, the mental is equally as important as the physical. Okay, so preparation is important. You may not get every single thing, and people will get it to different degrees as well. And just to reassure everyone, when we work in a transplant unit, we've done transplants for years, and everyone, is very familiar with the process and what to expect. So you're in good hands with the, not just the medical team, the doctors, but the nurses, the physios, the dietitian, everyone in the team. Now, on day 0, very anticlimactic, usually. And that's what you want. Okay, there's this whole build up to it, and all the bags come in this massive freezer, and it feels like a bit of a letdown. But that's a good thing. So you can see on the right here, that's the stem cells being thawed. So remember I said they were all frozen in nitrogen, and then we thaw them in the warm water bath, and we reinfuse it through your central line, for example, at permacath. How long it takes really depends on how many bags of stem cells that you have. There is a potential for an infusion reaction. It's usually mild. You don't react to your stem cells because they're your own. They belong to you, so you will never react to them. And what people actually react to is the DMSO preservative that I mentioned earlier that we need to put in. And some people can react to that. I must say that's very uncommon. Knock on wood, I haven't actually seen one, but we know they can happen. It's usually mild, and people may get things like fevers or chills or nausea or flushing, or the blood pressure drops drops a bit. If that happens, we manage it very easily. We just pause the infusion, we give a bit of Panadol, antihistamine, and some short-acting steroids just to calm the immune system down and go, hey, it's okay. We know what we're doing. There's always a doctor there. So our policy in our hospital is that we'll have a doctor present throughout the entire infusions, just in case anything happens. This last bit is a bit of a strange one. There can be a bit of an unusual smell to it. And again, that's, I think, more from the DMSO. But 50% of people can smell it, 50% of people can't. They just go, what are you talking about? I can't smell a thing. But if you can smell it, it smells slightly unusual. It's like a can of creamed sweet corn. That is exactly what it is. If you crack one open, that's exactly what it smells like. That can actually linger on for a few days. So your carers or visitors might actually notice it when they walk into your room, because you're probably sweating it up from your pores and things like that for at least a couple of days after, but it does go away. So don't worry about it. Now, what do you expect from the plus days? So from about day +1 to day +6, so that's when your counts are still not too bad, but they're starting to come down. Most of your symptoms over this time is very much related more to the high-dose chemotherapy that you just had. So the gut is probably mainly the main thing. Nausea, diarrhea will start occurring as well. So most patients will need regular anti-nausea at this time. That's very common. So we can maybe have 1 or 2 regular things and then addition on top of that if you need to. Your stools will start becoming loose, and we like to collect a sample immediately so that if there's no infection picked up in the lab, then we can actually start gastrostop, and that will really help you. You may get a bit of fatigue from the chemotherapy itself, and as I mentioned, your blood counts will progressively drop, and that's denoted by the yellow line here. And then from day +7 onwards, that's when it gets a bit tricky. So the blood counts will start hitting its what we call nadir phase. So that's the lowest point. Your hemoglobin will drop to less than 80. I've just put the normal values just for reference there. Your neutrophils will hit rock bottom at 0, and your platelets will drop to less than 10 to single digits as well. And a lot of the symptoms that you get over this period of time is very much related to your low blood counts, and not really the chemotherapy anymore, but actually specifically to do with the low blood counts. So anemia and thrombocytopenia, so your low red cells and your low platelets are usually quite easily managed because we can give you transfusions for it. But don't be surprised, you will get lots of blood transfusions while you're in hospital. The hemoglobin, we like to keep it above 80. For anyone who maybe has a bit of heart issues, we like to keep it above 90 at least. With low platelets, you might notice easy bruising. Some people might get problems with bleeding, not common. And we always transfuse. So you have a blood test every day, and anything less than 10, we would transfuse a unit of platelets. Or if you're having temperatures, because temperatures actually chew up your platelets quite quickly, we keep it above 20. And of course, if you're bleeding, we will keep it a bit higher. But the main complications actually come from this term called absolute neutropenia, when your neutrophil counts are at 0. All right. And again, the 2 main organs affect, as I say, is the bone marrow and the gut. So those are where the problem comes from. Now, so absolute neutropenia, infection. Almost all patients going through a transplant will have at least 1 temperature at some point in their journey of the transplant. Okay, it is very rare. I think I've only ever seen 1 patient so far went through the whole thing without a temperature, which was more surprising. So that's usually the exception rather than the rule. This is considered a hematological malignancy, emergency. We call it febrile neutropenia. So the reason I bring this up is because don't be surprised when you have a temperature, because it sounds like a mild thing, just having a fever. But you learn in hematology there's no such thing as just a fever, but it's a temperature and you might feel well, but suddenly you get all doctors and 3 nurses coming at you very, very quickly. And that's okay. That's what they're meant to do. That's what they're trained to do. And it's doesn't mean that it's because you're really, really unwell or you need to be worried. It's just because things need to happen quickly. And there's been studies that have been shown that, the faster you get antibiotics into your system, that is that will reduce the risk of more complications, essentially, and it's really important for your well-being. So the doctor will assess you, making sure you're stable, your blood pressure, your heart rate, examine you. You will have what we call a full septic workup. So you'll have blood tests. There will be they'll take cultures from your central line. They'll take it from your vein as well. They'll take urine samples and stool samples if they haven't already. They'll probably order a chest X-ray. And in the times of COVID, we'll always be doing a swab these days. We start antibiotics straight away. As soon as cultures are taken, we start intravenous antibiotics. We give strong ones, it covers a broad range of things. During this time, you might also need help with hydration. So there are a lot of what we call insensible losses when you have a temperature and you have no neutrophils. You lose a lot of fluid from just sweating, for example. And during this time, most patients also have diarrhea, as I will show in the next slide. And so most patients will be a bit dehydrated, and you may not be able to drink as much as well as you can just because you're not feeling well. So a lot of patients do end up needing a bit of help from us with intravenous fluids as well. Patients always ask me, where did I get this infection? I've been so careful. I'm in hospital in a single room. No one sick is visiting me. Where do I get these fevers from? Majority of the time, the source of infection is actually from yourself. And that's because all of us are full of bugs on our skin, in our mouth, in our gut, everywhere. And during this time, your natural barriers, particularly in your gut, your natural protective barriers are actually impaired. And so you're flicking off bugs every day, essentially, and that's what causes the temperature. So the main thing is to get antibiotics in. Sometimes we do grow a bacteria and antibiotics need to be changed, but most of the times we don't actually find a source. We will continue the antibiotics until your neutrophils recover to 1 or more, which is usually the time that you're about ready to go home. You'll also be put on a few other medications to prevent certain infections, so antifungals, antivirals that will continue over that time. This is the second issue. So besides infection, mucositis, which translates to inflammation of the gut lining. So as I mentioned at the start, every day we're turning over our mucus lining from anywhere from your mouth down to your anal region. We are making new cells and recovering, but you need neutrophils to actually be able to do that. You need neutrophils for a lot of things, and that's one of its most important jobs. So if you don't have neutrophils, the gut lining can become inflamed, and that can happen at any section. Again, you're not going to end up with all these symptoms. It's just some people end up with some of them or to different degrees. But essentially in the mouth, you might get a sore mouth or ulcers or painful swallowing if it's further down. We put you on mouthwashes from the start. We advise soft toothbrush so there's no injuries. And then we've got a few combination of other things we can use. Lignocaine gel, which some patients don't like because it makes your whole mouth numb, which can be a bit uncomfortable. Or cocaine mouthwash actually is quite effective as well. Nausea, vomiting, loss of appetite, and weight loss. We use regular anti-nausea. I would say to my patients, have small, frequent meals rather than large meals. Sometimes the smell can put you off. So even little things like when they bring in your lunch. Some people find that when they lift up the lid in the hospital food, that smell can really trigger nausea. And so even little things like telling the nurse or the staff, can you open the lid for me outside and then bring it in, can actually make a huge difference. And those little things can really help. Dietitian will be involved in your care very, very early on. And they'll recommend sometimes to supplement drinks. The trick is to find the flavor you like. There are many different flavors. There's vanilla and chocolate and strawberry. Find the flavor you like. It can be a bit thick and sweet. So a lot of my patients find that if they dilute it in ice, it actually really helps. It's diluted and it's less sweet and they can get it down more. I don't care what people eat at this time as long as they eat. So it can be low nutritious food, but high in calories. That's important. Okay. So whatever you can eat, whatever you feel like eating, do that. Colitis. So diarrhea is a big part of this. And as I said, we send a sample off very early on. And if there's no infection, we give gastrostop. During this time, because you might be losing lots of electrolytes from your gut, we also usually need to give you things like potassium and magnesium, either oral tablets or through the drip. Just to note as well that we do have other teams in the hospital that are very heavily involved in all our patients. The palliative care team is a great resource. People hear the term palliative care and they get, a little bit because of the connotations to do with that. But they see a lot of our patients, and the main role here is for symptom management. They're very good at it. They're better than hematologists at symptom management. Okay, so they might be called in if you have a lot of issues, mucositis and pain and appetite issues, to help you through all of that. Now, fatigue can be a huge part of this, okay? And again, that's also because you have no neutrophils. And when you have no neutrophils, you feel really, really flash. And also, you're trying to get through this whole thing that everyone's been telling you about this entire time. And there's a huge psychological impact. So I think the main thing I would say is, there are other services that we have available to us in hospital, pastoral care, the psychiatry oncology team. You're not in this alone. And to use all the services that you have around you, don't try to be stoic. We're all here to help as well. You can bring things in with you to help yourself keep occupied, but a lot of times you may feel that you don't feel up for it, your concentration is not as good, and that's okay. That is completely fine. You just do things when you feel like it. Exercise is a good thing to try to do only when you feel like it. If you feel well enough, some gentle, regular exercise, just walking around the ward, for example, helps with sort of mental, emotional health, helps to maintain your muscle mass, and it does actually help neutrophil recovery. We know that exercise actually can help stimulate the bone marrow as well. I think I'm just checking the time. All right. Okay, so day plus 10 to day plus 14, that's when we start to show signs of recovery, and you get very excited, doctors rushing in the morning going, did you see your neutrophils? There's 0.1. We're very happy. The amount of excitement that we get as hematologists from these things is quite sad, really. But but we get very excited about it. And oftentimes my patients actually tell me, and we can see it on the ward rounds, that you start feeling better in yourselves before we see the numbers improve on blood tests. So I might walk in and the neutrophils might still be 0 on the day, but patients tell me, oh, and I'm feeling better. I'm just a bit more energetic. My diarrhea is settling. And then we see that the fevers are starting to settle, the appetite's improving, and we go, I think your counts are coming back. We probably will see movement in the next day or two, and oftentimes that's, jackpot. Neutrophils are usually the first to recover, and then followed by your hemoglobin and platelets. So you will still likely need transfusions for another week or so, sometimes, not always. Requirements for discharge. So this is when the patient starts saying to me, when can I go home? That's when I know that you're well, when you start asking me, when can I go home? So we like to see the neutrophils go above 1, no ongoing fevers, no active infections, you're eating and drinking, you're up and walking, and you're feeling okay doing that, and your diarrhea is controlled or at least on the improve. So post-discharge expectations. From a medical point of view, I usually like to ask my patients to do blood tests once or twice a week for the first 2 weeks. You may still require transfusions at that point, or you may not. It might just slowly start to rise. And we take the permacath out when you no longer need transfusions and your platelets are above 50, so it's safe to do so. You may still need some electrolyte replacement because you actually need a lot of potassium to make new cells, and so that's what we see at this point. In terms of reviews, you might have a review with the nurse coordinator about 2 weeks post-discharge, and we like to see our patients, the doctors like to see their patients about a month post-discharge as well. Expectations for general recovery. So it is very, very important, and Michael talked about this, to set realistic goals. Oftentimes when patients are ready to go home, they feel that they're well enough and they can do a lot of things. But remember, you're in hospital where there's not much to do. But when you get home, a lot of people find that they're surrounded by the normal environment. So they try to start doing things they normally do. And that's when they really feel the fatigue. And that's very normal. We see that a lot. Patients report that a lot to me. It's very common. It takes about 3 months post the transplant, so post-discharge, for people to start to feel like they're back to normal. And what defines normal? Again, that's different. And some patients take even longer than that. A few months, sometimes up to a year, to start to feel some sort of sense of normality. And that's okay. So the fatigue can persist and take time to recover. So pacing yourself is important. Scheduling rest in between, even if you're not feeling tired, you schedule rest so you're not going from 0 to 100. You take breaks. Exercise what you can, start slow and build up. Your concentration may be affected, and as I said, set realistic goals, and biggest thing is to be kind to yourself. Your bowels can take time to recover as well or go back to normal. I do have a handful of patients that actually tell me that the bowels have never gone back to normal after a transplant, and this is a few years down the track. Infection risk, even though your neutrophils would have recovered, it still takes time for your immune system to build up after a transplant. So all the usual things, which I'm sure everyone is very good at: avoid crowded places, wear a mask, hand hygiene, avoid anyone who's unwell, anyone who's sick shouldn't be coming to visit you. In terms of work, there's no one size fits all. Everyone is different. It depends on your work as well, and depends on what suits you. Usually about 3 months before people find they're ready, consider starting with part-time is what I tell my patients. And then emotional support is a huge thing. You've just gone through this thing where everyone tells you it's this giant process, and then you go home and it can kind of all hit you. Because sometimes you're just working on adrenaline and survival instincts when you're going through such a big thing, and then you go home and then you have time to process everything, and that's when it can come out. So support groups are available: Leukemia Foundation, Myeloma Australia, Lymphoma Australia. You're not alone in all of this. And this is the second last slide. So post-transplant vaccinations, I won't go into detail because we've sort of, wiped out a lot of your cells. We need to revaccinate you from all the vaccinations that you've had when you were a baby. And we do 3 months post-transplant for COVID and flu, and then 6 months post, we start the schedule for all your other vaccinations. And I think this is my last slide, actually. I've just added a little bit of maintenance therapy that is specifically for myeloma patients only, not in lymphoma. We usually start this about 3 months after the transplant, so in line with the fact that the bone marrow and the counts have tended to have recovered and stabilized then, and you feel reasonably well. And the rationale in myeloma is to try to maintain your remission for as long as possible. We use lenalidomide, which most patients would have had as part of the upfront treatment. That's available on PBS, but there are also clinical trial options available to try to see whether there's any other drugs that we can use to actually deepen that response. The most important thing with maintenance therapy is that it should never be at the expense of toxicity. Okay, it's all about quality of life. The reason we treat your cancer is so that you can go and live your life in a way that is satisfactory to you. Okay. All right, I think I'm actually right on time. It's just unbelievable. Thanks everyone for listening.
I think you're right. Thank you so much, Dr. Sim. That was a great presentation. I think, autologous transplant is an incredibly daunting prospect for a lot of people, and you have just walked us through the whole procedure, but particularly the hospitalisation, the very intense part of it, in such a very clear and informative way. I'm sure that our audience will find it very helpful. Appreciated. All right, so that draws the presentation part of the seminar to an end. So if you're staying for the question and answers segment, please just stay online. We're going to stop the recording in a minute. Next week in our final session, we will be covering health and wellbeing after transplant, and we look forward to welcoming you then.